Good evening, friends, and welcome back to the Thursday teaching sessions brought to you from LTMMC Scion Hospital, Mumbai, and courtesy Alpha Max, a division of Alchem. We once again thank the authorities at Scion Hospital, Dr. Radha Gildial and others for allowing us to conduct these clinics and to bring them to all of you. Today, the first case is being presented by Dr. Rais.
Good evening, everyone. So, 5-month-old female child, third by birth order, born on non-consanguineous marriage, resident and hailing from Osmanabad, Hindu by religion, Maratha by community, brought by parents, informant being mother, reliable, with complaints of fever since 3 months and rash since 5 days. History of present illness. Child was apparently alright 3 months ago, after which he developed fever, which was insidious in onset, initially mild grade, documented 99 to 100 degree Fahrenheit, relieved on taking medication, not associated with a rash. Fever occurred mostly at night, not associated with any additional symptoms. Child was not active in interfebrile period, but accepted breastfeeds and passed urine and stool adequately. But on enquiry, mother gives history of decreased activity since birth, which I will elaborate on my birth history. For these complaints, child was admitted in Tuljapur for 4 days from 15/12/2022 to 20/12/2022. Some blood tests were done, received IV medications, and patient was symptomatically improved and sent home. Then child was at home for 20 days. Blood tests were done and taken treatment on OPD basis since the fever recurred again. Fever persisted, moderate grade, relieved temporarily on taking medication, developed maculopapular rash and edema initially in face and progressed to limbs and body. Patient was referred to DY Patil, Pune on 10 February 23, was admitted there for 8 days. Detailed workup was done including blood investigations, sonography, MRI brain and lumbar puncture. Patient received 1 PRC transfusion and IV antibiotics. Rash and edema subsided, but fever persisted. Child took DAMA and went home on 18th February. And child was at home for 32 to 40 days. Fever was persisting, more in the evening, mild to moderate grade, 100 to 102 degree Fahrenheit, not associated with a rash. Activity was moderate and child accepted breastfeeds. Complaints of high grade fever since 10th March, associated with rash, erythematous, blanchable all over the body, associated with flushing, which then progressed to black punctate lesion with a few vesicular lesion over the span of 4 days. Child was admitted in Barshi for 2 days, referred to LTMGH Scion for further evaluation and management. No history of cough, cold, respiratory distress. No history of irritability, ear discharge, excessive or inconsolable cry or convulsion. No history of yellowish discoloration of skin. No history of decreased feeding. No history of cry during maturation or decreased urine output. No history of bony tenderness or joint swelling. On enquiry, mother gives history of child not making eye contact and not fixing and following. Also history of decreased activity and preferring to sleep since birth. Mother also gives history of child rubbing and poking of eyes frequently. Moves head towards the direction of sounds, reaches to lights turning on and off. Mother also gives history of sudden jerky movements in form of flexion and adduction of arms, extension of lower limbs, sometimes associated with loud sounds, 5 to 6 times per day, and there is no other significant past history. ANC history, spontaneous in conception, registered pregnancy at 5th month, iron and folic acid tablets taken, 2 doses of TT taken, history of fever for the mother, moderate grade for 3 days, not associated with rash or lymphadenopathy in the 5th month of gestation, no history of jaundice, pruritus, hypertension, diabetes mellitus or hypothyroidism, birth history, full term LSCS in view of previous LSCS, birth weight was 2.5 kilogram, baby cried immediately after birth, no NICU stay, history of neonatal jaundice at the day of life 3, received phototherapy for 2 days, no history of exchange transfusion, discharged on day of life 5. According to mother, after neonatal jaundice event, child was lethargic and preferred to sleep but woke up every 1.5 to 2 hourly for feeds. Activity is decreased as compared to elder siblings. Immunization history, only birth vaccines received according to National Immunization Schedule. Dietary history, exclusively breastfed up to 2 months. Started on formula feeds Lactodex as advised by local practitioner. Currently on breastfeeds with formula feeds with 2 to 3 night feeds. Developmental history, gross motor, there is only partial neck holding. Fine motor, opening and closing of fist. No hand regard, mouthing or bidextrous reach. Social smile present. No fixing and following, does not recognize his mother. Language, cooing present. No babbling or laughing. Impression, global developmental delay present. Developmental age comes around 2 months. Family history, there is history of sibling death at 2 months of age due to congenital heart disease with pneumonia. Then the second child, 2.5-year-old male child, alive and normal. Impression,
Go to the next slide. Okay, so let's start with the first symptom. So fever was noticed at about 2 months of age when this child was 2 months, right? So when you get a 2-month-old infant with this kind of a history, low grade fever, what would be your thoughts? Can it be a viral infection? So what will decide whether it's a viral infection or no?
Viral infection will be with high grade fever spike and child would be active in interfebrile period. Fever will not last for this long time of 3 months.
So for a minute we will also discuss this interfebrile period properly, when to use it, when not to use it. High grade fever is our concept. So it's actually this way, that if fever is high grade, it is often viral. High grade at onset. Doesn't mean viral fevers cannot be low grade. It also depends on the age of the child. What will be the intensity, high, low. So just because it's low, don't rule out viral. But I just want to bring out one important point that you must always remember for a 2-month-old. What is that? 2-month-old and viral.
Common, uncommon, we'll make it MCQ, no? It answers are faster. Common, uncommon?
Uncommon. Why uncommon?
Why uncommon?
At 2 months, we will suspect bacterial infection or any serious illness first.
Okay, that you should suspect bacterial serious. But why viral is uncommon at 2 months?
Antibodies are there, so good defense.
Any other reason? Excellent, less exposure. So that is the bottom line. So in a 2-month-old who's largely within the house, unless there is a household contact, you will not think of viral, or you will think of it lower down. That's One very important point to remember, right?
And the commonest household contact that you should suspect is an elder sibling, okay, in the house.
Now, interfebrile period. So, what is why do we use this terminology? We want to say active in the interfebrile period or sick in the interfebrile period. So, first of all, if it is 99 fever and then 98 fever, is this really interfebrile period? You're getting what I'm trying to say? 103 and 98 is interfebrile. So first thing is, for low fever, don't use this description interfebrile period. Okay, it is not right. Low fever. So you use interfebrile 1 month, there is no interfebrile period. It's a very long fever, so there are a lot of constitutional issues coming in. So again, don't talk of interfebrile period for a long fever.
And if at all you talk about it, make sure that you pay attention in the first few days, whether it was, what was the situation interfebrile. So as Dr. Rajesh said, subsequently whatever is happening is not considered interfebrile.
Okay. So first thing we said is that we will not take it as viral. Okay. Now this is low grade fever. So now this not active, we will not really give it a lot of importance, because you said right from birth this baby was little dull or lethargic or whatever. Yeah. So why do you think that is the cause? Why, means the history was delivery was normal, right? So why is this baby lethargic from birth? Hypothyroid?
He had history of jaundice as well, neonatal jaundice.
So jaundice made him lethargic, you think?
It could be incompletely treated bilirubin encephalopathy.
Correct. So now from the history that you have got, tell us strongly you are thinking of bilirubin encephalopathy, or you are strongly thinking it is not bilirubin encephalopathy. From this history you have to judge. Come on, what are the points in favor of? So what happens to that baby at the time of getting that bilirubin encephalopathy? So what will be that baby 2-3 days prior? What will be that baby on the day the bilirubin hits the roof? And what will be the baby after that? Behavior.
In the initial phase, 2-3 days prior, the child will be irritable, and there will be crying which will not be consolable. Then later on lethargy will set in, and the child may also have seizures. And the last stage would be the child would be very dull. There will be poor suck and reduced activity.
Yeah. So good. So what you are saying is, before that you have to precede it with a normal baby.
Okay.
So normal baby then gets high jaundice, then becomes irritable, shrill cry, all that. That's the time the baby is getting the encephalopathy, and post that, it's been 3-4 months. So what will be the behavior of the baby post that?
Post-carnicterus or post-neonatal bilirubin encephalopathy.
So you expect some symptoms, some complaints from the mother? A baby who's gone through carnicterus, how will that baby be at 4-5 months of age? What all will be abnormal in the baby? Will the tone be normal?
Increased tone.
So dystonia, some symptoms which the mother will complain of, right? So in this baby, it seems less likely that the lethargy is due to bilirubin encephalopathy. In fact, he is saying it's from day one.
Can you not bilirubin encephalopathy? You have to have a frank carnicterus to call it bilirubin encephalopathy, or the baby can have subtle manifestation. Bilirubin is 20. There was no bilirubin encephalopathy. But this baby later on turned out to have impaired hearing, delayed development, altered tone. So don't go by the typical picture of bilirubin encephalopathy. Do you think these days anybody will get that bilirubin encephalopathy? There may be subtle problems, the phototherapy may be started, but yet in your mind you keep that the bilirubin was high, and therefore you can't simply say that more so if the baby is preterm, more so if it is low birth weight, because you know that they can get it at a younger, at a lower level of bilirubin, and the manifestations may be more subtle. And also in this baby, the baby was discharged on day 5, the bilirubin encephalopathy, the frank encephalopathy will not get discharged on day 5. And he was given phototherapy. Who will stop his phototherapy when the bilirubin is high? So none of these suggest that there is any chance of bilirubin encephalopathy.
Can you give a thought whether this could be hypothyroid? He's saying from day 1 lethargic. What are the points for and against?
Sir, actually the mother is saying the lethargy started after the neonatal jaundice event. So,
Okay, mother is saying that it started after the jaundice event. Fine.
And day 1 lethargy is also difficult to judge. Okay, the baby is sleeping 22 hours after 24. So how do you know that baby is lethargic or no? Little later you can say with some degree of confidence that it was or it wasn't lethargic.
And I think the neonate who presents with hypothyroidism is almost athyrotic. That's why the presentation is right at birth.
Yes.
And if that is so, baby even doesn't wake up for a feed. The child is just sleeping. Okay, this child seems to wake up off and on for feed. Okay, earlier the presentation, worst is the hypothyroid state. And to that extent, this doesn't look like a hypothyroidism, right?
Okay. So now this baby was admitted somewhere and received some treatment. So
I think talking about fever, we said that it's not really gelling well with any simple infection that we are talking about. Now, knowing that this baby was not normal, what can be the risk factor of this abnormality in terms of relation to fever? What I mean is, I want you to discuss how the developmentally affected neonate, what are the risk factors to get fever? Infection is one, but doesn't look like this. Okay, why should a developmentally affected baby get fever, aspiration, pneumonia, whatever? Did not look like that. So barring infection, what are the risks of other illnesses to such a developmentally affected baby? You get the question right?
Fever with rash in the, fever in the mother, some congenitally transmitted illnesses.
you are saying congenitally transmitted infection in the baby. So good thinking. Now we'll have to explain why no fever for the first 2 months. Baby was 5 months old and started getting fever at the age of 2 months. So in a congenital infection,
Dehydration associated fever, but
okay.
later.
So maybe a short fever, yes, but not such a long fever. Anything else? So because this baby is developmentally abnormal, maybe where could the problem be? CNS. Now can you link anything about temperature there? So there could be some damage to the temperature regulating mechanisms there, and that could be one way. This could be a non-infective fever, right? Okay. Now if I don't means as at this point we don't know whether we are really ruling out infections at this point. This is at 2 months, 2.5 months when there are a few days of fever. So what other thoughts come to your mind? What infections are you thinking of? As time passes, of course, our thinking will change. And he said low grade fever. So what infections are you thinking of? You all want to pitch in? Any thoughts on low grade fever? Commonest cause of low grade fever.
I think looks like it's not a viral infection. So we are looking at what could be the bacterial infection which has no other symptoms than fever at such a small age. Tuberculosis, yes. Typically tuberculosis coming so early could be one, a congenital tuberculosis which does not even present with fever, present with hepatosplenomegaly. Okay. And suppose it was acquired, even at that age, 3 months is the right time for an acquired TB, acquired at the maternity home. In the next 6-8 weeks, the child starts manifesting. In which case, the spread of a disease is so fast that you almost get a miliary TB presentation at that age. And therefore, yes, good thought. Okay. What could be the other reason for bacterial? See, we are considering only one type of infection where there is a contact. Can child have no contact at all with any infection, and can he still get a bacterial infection at 3 months of age?
Immunocompromised.
Immunocompromised must meet the contact. If I am immunocompromised, if my house is open throughout the night, it doesn't mean there will be a thief. There has to be a thief first. And then even if my house is closed, the thief can walk in. So immunocompromise will get only when there is a contact. I am asking you, which infection one would be at risk at 3 months without a contact, gets on his own?
UTI.
Excellent. And why does that happen?
Normal flora.
All of us have normal flora.
Ascending infection from the...
So some obstruction and retention, and that becomes the nidus for a back.
And while we'll think of UTI as a possible cause without, still you will say it's not UTI. Why?
Means sir is saying in this child.
UTI possible, but UTI unlikely. Low grade fever. Such small babies with ascending infection, they have not lower UTI, they have pyelonephritis. Abrupt onset of very high fever, at the most there may be low fever for a day. It's a sick child. Okay, so low grade fever for 2-3 months with UTI in a small child like this, with urinary abnormalities, either in the phosphastasis or reflux, not likely.
So at this stage we are not clear. We've discussed 2-3 possibilities. We are not very convinced that infection, because if infection, then how has it progressed? Where is the infection? We have no clarity. What treatment was given, we don't know.
Non-infectious fever. April, May month, staying in a kacha chal, upar shade se patre
So
ka.
she said dehydration fever a while back.
Yeah.
So, we are not clear on that, and then treatment was taken and fever recurred again, it says. Now fever has become moderate grade and he's developed a maculopapular rash and edema initially in the face and progressed to limbs and body. Now, what was the age roughly at this time? Means how? 3 months. So 1 month later. Okay. Now, do you want to ask more questions? And now I want you to talk about your thoughts of the rash and your thoughts of the edema. So, do you want to ask more questions about the rash?
What do you ask about the rash? Come on, come on. More energy.
Color of the rash?
They ask, you can answer. You have a mic with you? Thank you.
From where it started first?
It was in hands, legs and face. It actually lasted only for 2 days.
Fair enough. Anything else?
Type of rash?
Type of rash?
Maculopapular.
Maculopapular. He has written over there, right?
So why did you ask where did it start? What is the importance?
Some typical pattern of rashes like measles start from behind the ear and chickenpox from centripetal.
Okay.
3 months of age.
So your question for
Absolutely,
a rash in
yeah.
general is right, but here you have to modify the question. So that's what we tell you about negative history also. That in general for a symptom you have 25 questions on negative history. But in this situation many of them get obviated. So same is about the rash, that this rash, if it is so long, then that where it started and all becomes little less important from these points. Anyway,
but the
go on.
distribution may still be important.
Yes.
Like where was it, where did it appear? Suppose it went on for only 2 days. Then which part of the body it affected, whether it affected overall. Like he described, it was from hand, face and body, everything.
Hands and limbs.
And limbs.
And how long did it last?
2 days only, sir.
Only 2 days, and then it went away.
It went away.
Edema?
So what do you make out of this rash first? Tell us, you can even tell us what it is not. We may not know what it is, but you can tell us what it is not. So is it a viral exanthematous illness?
Unlikely, no? We said virus is unlikely, so viral exanthem is less.
So be confident and say which viral exanthematous illness has a guest appearance of a rash. No, so it's out. Okay? Now, is it a sepsis? No, it's not sepsis. Is it drug-induced rash? Yeah? Suppose it's not associated with edema, even then, for on its own merit, how will you take the rash as a drug-induced rash?
Purple color more on the lips, genitals and on the extensor surface, annular.
And I thought it lasts longer than 2 days. Doesn't go away in 2 days, right? So therefore unlikely to be a drug-induced rash also, right? Now, which situations do you know of a temporary or a evanescent rash?
So it could be an urticarial rash.
Okay, it could be a...
Maculopapular with edema.
So urticarial rash, yes, but at this age it will be difficult to judge.
Again, urticarial rash in very young infant is unlikely. And secondly, urticarial is classically a papular rash and not maculopapular. But I totally get it that at a 3 month from a history which was 2 months back, rash only for 2 days, you may not have accurate details and keep your options open. But 3-month-old having urticarial rash is extremely unlikely.
So I asked you which rash do you know which is temporary?
Evanescent rash, which comes with fever and goes.
So tell me exactly what is the meaning of that evanescent. It's not here, but I'm asking you just for understanding.
So it comes with the fever spikes, and when the fever spikes is down, then it goes away.
Very good. So that rash is literally for a few hours for the spike of the fever, right? And that is seen in our systemic inflammatory disorders. Okay. Sir.
So I think in this child, the rash has come up some time later than the onset of fever. Okay, most of the rashes come either with fever, immediately with fever, or within a day or 2 or 3 fever, and majority of them get better after the fever goes away. So this child has had fever without a rash for a while, and then comes fever with a rash, and then the rash disappears. So the question is, what kind of such manifestations are occurring? One possibility is really it has nothing to do with the primary cause of fever, and drug fever is still possible. It lasts for about 2 weeks and then disappeared because the drugs have been changing, obviously. The second possibility to my mind is this some chronic persistent infection which is low grade, which keeps on keeping different symptoms at different times? Okay. I'm sure we are looking now for some infection which has never cleared completely. Nor there is a clear evidence to say that there was a serious bacterial infection which was partially treated. So this looks like some chronic process that is causing fever. Then the question is, when you look at a chronic infection, then it could have multiple symptoms coming, going, but the disease goes on. Simple example is tuberculosis, a fever off and on. Fever disappears, but the illness continues. So one important thing I want to know is that how is the child's health going down or health is maintained? Not easy to pick up on the history, but suppose you ask whether apparently there has been a reasonable good weight. This child has been always going to the hospital with the doctors. So are we able to make a difference between a chronic process with a disturbed health, progressively worsening, vis-a-vis a chronic process but not worsening health status, which will make our understanding a little better what kind of illness we are looking at. Okay, let's believe that this child must have had a worsening health status. Let's believe that. To which it means that there is a chronic persistent problem. Okay. Then at that stage I want to know how well is the feeding. Apparently you said feeding. So why is the child feeding? Now feeding doesn't mean feeding adequately. Feeding means some attempt at breastfeeding. So all that might have different. For example, you're talking about a congenital infection. Now if a congenital infection of varieties of time may persist for a long time and the presentation may keep on varying. Sometimes you might get some organ involvement, sometimes you may not. All that. Okay. For example, earlier days, I'm sure Dr. Khare has also seen, congenital syphilis was not rare. Came with a rash, came with multiple symptoms, multiple organs, but failure to thrive was a predominant feature. Even the neurological manifestations were very vague. Okay, not doing well, not clear dysfunction of an organ. So I'm looking at first whether there is a chronic process disturbing the health or not disturbing the health. That might make us some headway to decide what are we looking for. But so far I agree that we have no idea where we are looking at all, right?
So the first 2 lines where we discuss that this is unlikely to be a viral exanthem, what we mean is there are 2 viruses which I can consider here are dengue and chikungunya, which in early age group can come with fever, maculopapular rash and third spacing related edema. We are not saying that it fits into here, but just to tell you that when we discuss no virals in young kids, we are talking about viruses which come through respiratory pathway or touch or contact, etc. But mosquitoes can bite anybody, and so you can have, we have seen children with chikungunya with very bad rash and pigmentation, and young infants with dengue is also been known. Not in this patient, but otherwise.
And I think this child has been in and out of hospital. So this child has been in contact with varieties of infections, including the hospital infections. So we do not know what started off was different and what kept on complicating was another different. So we are open at this stage, and we must say that we are not able to pinpoint where the problem is so far. Okay.
Now just to make our thought process right, this child developed edema and it says it started on the face. So do you think this is a nephrotic kind of a thing which we normally see?
Say yes or no.
Whatever. You can say yes, you can say no. We are here to learn.
No, less likely because associated with rash also. But
Suppose
edema,
it is not associated with rash.
and
Take its
Was it
take it
persistent
only
or
as edema. So take it as a 3-month-old with edema on the face and think whether can it be nephrotic.
associated with, we'll have to ask about decreased urine output, or how long did the edema last? Did it resolve on its own, or was it
Right. And what
persistent?
else? One most important thing which every nephrotic will also have along with that edema. What do they have with edema? Abdominal distension?
Okay. Huh.
They should have abdominal distension or no?
Ascites.
Hmm?
Yes.
Okay. Can this be liver disease? Edema, face, then arms, then legs.
Liver disease present with ascites first.
Okay,
More
it
commonly-
presents with ascites first. What else?
Icterus.
Huh? Icterus. Okay. So good. So there will be many other aspects of hepatocyte dysfunction that will show maybe before all this shows. So
No, no. Just on the chat, there were two comments. One by Dr. Palniraman about UTI that we discussed under 3 months to be looked first. And by Dr. Pramod Kulkarni is whether this drowsiness or less activity can be attributed to any inborn error of metabolism.
Can it be nutritional edema? This child has not been doing well. Right from birth, his feeding is plus minus. And when he has fever for such a long time, he's in negative nitrogen balance. There's no other cause for edema for this particular child. But nutritional edema cannot be. You don't get that typical kwashiorkor-like picture where long-term nutritional deprivation has occurred and changes for skin, bone change, hair changes to occur. Nutritional edema can come relatively fast in this child.
Sir,
And it
in
has
fact-
gone down also and come up also. So this is something which will, whether it has something to do with the ultimate diagnosis, fever is different story. But this edema is most likely nutritious.
So I was trying to lead them to that it is not kidney disease, it is not liver disease, it is not heart disease, but it is nutritional. You should
I think this edema is with fever and rash. So which is this edema which comes with fever and rash? Only two types. One, what you were saying, is it a complication of a viral infection, capillary leak, whatever? Or it is any trivial infection that makes it nutritional edema manifest as an acute onset edema. So why is acute onset edema nutritional? It's chronic. Can acute onset edema be nutritional? And answer is yes, because they are all already at a low protein level. Okay, the manifestations come up acutely, but the nutrition is suffering already. And typical kwashiorkor that we used to see earlier was always an acute onset edema after 1 day of diarrhea. He was just waiting for an aggravation. And I think that's the most likely cause on this child. And then some temporary control of that infection, the edema may even disappear. The question is now, what was lethargy was also hypoproteinemia? What's your comment? Now it becomes the kwashiorkor only.
So what do you think? You should be able to refute, sir, on that. That lethargy
Or
is not
at least
due to-
accept.
Come on. Chronology. What's the chronology?
Fever first.
And even before fever, what started? Lethargy started right in the beginning, no? So it cannot be due to this hypoproteinemia, right? Okay. Fine. Now let's move on. So now recently sorry. Huh. Yeah, child received one PRC transfusion and IV antibiotics, and rash and edema subsided but fever persisted. So any comments or any thoughts on that?
So it can be anemia of chronic disease.
Okay, anemia of chronic illness. Yes, I am not able to make out much from that PRC transfusion as a addition to the diagnosis.
I think it suggests that this child must be malnourished already. And therefore, when the malnourished child comes with sick, even a moderate anemia may justify a Paxil transfusion just to build up a child. The point is that antibiotic has no reason to get rid of that rash and edema. It disappeared either because of the capillary leak-like complications were treated by IV fluids, by control of infection, or some resuscitation, nutritional, temporarily the thing improved. So I'm sure that this kind of ups and downs are occurring not because of the same process with which the whole story started, but it has been intervened by multiple interventions, and I think that's why the whole story looks quite not related to one progressive illness, and I think we will ignore it for a while. Something happened and something disappeared, so for a while we are okay, but the fever is still persisting. So the problem has persisted of fever in between.
How do you know it is Paxil related first? It may have been whole blood also. What do the parents know whether it's Paxil or something red inside? It was a platelet transfusion, white blood transfusion, yes. This was for them blood transfusion. Because you are very rational, you give Paxil transfusions. But it came in the blood also, and it got in plasma, and the edema subsided.
Okay, now there's high-grade fever with rash, erythematous, blanchable all over the body, which then progressed to black punctate lesion with few vesicular lesion over the span of 4 days. Any thoughts on this? So, I mean, as sir was saying, there could be multiple things, so this could be another intercurrent illness as well.
What do you understand by blanching rash? And what is non-blanching rash? Does that make us know something better about what's happening?
Yeah.
So vasodilatation causes blanching.
Vasodilatation causing blanching. Anything else?
How do you get history of blanchable rash? I find it very difficult. Because classically we say blanchable by pressing a slide, a glass slide, correct? To get a history from mother. So it's interesting. It's good you got the history. Can you tell us what the mother said about this rash?
Mother said the red color decreases when touching.
Fair enough.
Mosquito bite, and we are looking at chronic malaria. Blanching rash, right? The most common one.
Yeah, I think this rash he means to say is blotchy erythema, not just macules or discrete. That's what you mean?
The last slide.
Okay, but yeah. He'll show the picture of the rash.
There was punctate black lesions all over the body with a few vesicular lesions in upper limbs and lower limbs. This was after admission.
Okay, now we come, so I
Just
don't
one
know.
point that vesicular eruption is a reasonably common way of a early neonatal or infant manifestation. So we need not talk about what are the infections causing a vesicular rash. Okay, some vesicles must have seen, and I think that's a common response of a very small infant to multiple reasons. This child has maculopapular rash and also some vesicles. So again, we do not know. What we want to probably guess at this point of time is, has this been an inflammatory disease? Infection or not infection is the next thing. The skin rashes look, vasodilation you said, blanching, whatever. So looks like an inflammatory process of whatever reason. Toxin induced, infection induced, non-infective. But that is where we possibly stay at this point.
Sir, these black punctate lesions, can they be vasculitis?
Well, at this point, no. Okay, but again, here we are not sure. We are not looking actually at the patient, so I would not be able to comment on what kind of thing.
And he has nicely mentioned that the lesion progressed to black punctate lesion. So it could be just a secondary change or a healing rash, a vesicular healing, or a like an acne which is healing, something like that.
Okay. Now we come to the developmental part. So child is not making eye contact and no fixing and following. So do you think this is autism? Not making eye contact, no? Yes, so 5 months old, so early diagnosis.
Autism, and she's too small to diagnose autism.
He's too small to diagnose autism, yeah, but what I mean is that how do you interpret this not making eye contact at this age? Vision problem. So you will first take it as whether there is a faulty vision, right? Okay. And no fixing and following. Then decreased activity preferring to sleep. So now,
Where is the vision problem?
where is the vision problem? So what sir means is that, is it
The anterior segment, that means the eye, including the retina, or is elsewhere. The child may not fix. What he does not fix means maybe he is able to see, but he doesn't find your face interesting enough to focus. And how do you know he is focusing or no? When you move from side to side. And if the child also moves, then he is focusing. If he is just looking at you, he may not be focusing. But if he is focusing, and if he is not, so here he is not focusing. He is not even looking at you. So this particular child has impaired vision. So where is likely to be the impaired vision? How will you separate little later with examination? It could be anterior segment or it could be behind. What is known as cortical blindness. So if there is a anterior segment problem, then what will happen to reflex dash dash dash, and what will happen to the same reflex when in the cortical blindness?
So white reflex due to cataract or
hold close?
Whatever light reflex will be present when there is anterior segment is intact, but the child cannot see, and light reflex is absent or a cataract or something is seen, then you know that the anterior segment is affected. Okay. In cortical blindness, the light reflex is present because the anterior part is there. He may be seeing also, but he doesn't know what he is seeing. He doesn't have an interpretation.
So, few comments from the chat box. Dr. Palinaman says vasculitis can present with rash and edema. That we discussed. And he also mentions scrub typhus in his area. He comes from Tamil Nadu and around. So, scrub typhus can come with fever, rash and edema as well. He said the rash, whether it is a blueberry muffin rash, is something which you should look at. So what is blueberry muffin rash?
Rubella.
Rubella, okay. Anything else?
Extramedullary hematopoiesis.
Neuroblastoma typically with skin mets or whether skin spread, whatever word you want to use, can also present as blueberry muffin. And Dr. Pavitra has asked whether we can see previous videos. So I'm just taking the opportunity that they can go on to the site clinicalpediatric.co.in and see, as well as they can see on the IAP platform.
Yeah, so www.clinicalpediatrics.in, the original site, there was a big technical problem. So it is, the previous videos are gradually being uploaded on the site. So yeah, you can go and see on the site. Fine. So this lethargy and this vision problem, which we are told is right from the beginning, from the early days. What do you think? It is prenatal, perinatal, or postnatal? Because later we have been told that there is developmental delay, global developmental delay. So this developmental delay is prenatal, perinatal, or postnatal?
Mostly prenatal, because there's no significant natal event. The birth event was like not significant. And postnatal also, it was just jaundice, which was not, severe enough to cause encephalopathy.
Okay, very good. So it is prenatal. So now in prenatal, we want to hazard a guess at big categories. So what are the big categories of etiology which can cause prenatal developmental delay?
It could be some maternal fetal like it could be some infections which are transmitted, maternal infections transmitted, any chromosomal anomalies.
So one category is congenital infections, one category is chromosomal anomalies, then congenital malformations, then what else?
So the female child, so can we give a thought to mitochondrial disorders? So
Mitochondrial, so metabolic disorders, okay.
Metabolic disorders don't present prenatally, okay. But the drugs and radiation, okay. So maternal drugs, for example, the mother is on anti-epileptic drugs, okay. So maternal drugs, exposure to radiation, besides chromosomes and congenital malformation and then congenital infection, these are the largely prenatal ones. Which one is most likely here? There is no history of drugs, radiation, etc. So we push that aside.
You can, for purpose of remembering, in prenatal causes you can broadly divide it in genetic and non-genetic. The implication is non-genetic will not recur. For example, exposure to radiation, drugs, intrauterine infections, they will not recur. While genetics are capable of recur. And in genetic you have the chromosomal, then genetic, and metabolic disease like MPS, etc. And sometimes even diseases like thyroid. So a list of about 6-7 causes here and list of about 4 causes which are non-genetic.
So which one is likelier, or which one can you rule out first? Drugs and radiation we have ruled out. Now, congenital malformations. Points for and against.
Which congenital malformation, if at all, you are thinking here?
If there would be any congenital malformation after birth of baby, we would have pointed out, or any congenital or ANC scan would have picked up.
Yeah, more than, scan will pick up, yeah, but I'm just saying from the way the baby has presented, what would you think? Which one would you put higher or lower? between congenital malformation, chromosomal anomalies, chromosomal oblique genetic, and your congenital infections?
More likely congenital infection, not in first trimester, but in second trimester, mother has history of fever with rash.
Okay. Anybody else? Any comments?
Genetic abnormal chromosomal, yes. There may be no so very obvious abnormality like cleft palate and deformed ears. Subtle differences, I won't say are not easy to diagnose unless you are a syndrome specialist. And there are subtle problems here and there which make a group diagnosis of syndrome possible. And I must say that we are not very well conversant with most of the syndromes. We know few of them and we can diagnose them, but syndromic association and therefore a prenatal cause, genetic, but non-infectious is also to be kept in mind. That may be even second in order.
If you correlate the probable prenatal problem with the story that has come up thereafter, then I think it's likely a maternal infection. Because however malformation or a chromosomal anomalies may exist in a child, there is no reason why such a child just goes on with progressive fever and all that. So if you want to correlate the two, of course two may be independent, yes, but let's try to push both all together, and therefore where it fits in mostly is an infection. Now, if it's a maternal infection where there is no story, which one? Now we want to know whether which maternally transmitted infection could continue to be active infection even postnatally. So it's not a damage. Okay, you get my point? Active infection starting prenatally and continuing postnatally. Whereas many infections would have just made a damage and then left the damage without activity.
HSV, she said. Herpes simplex, she said, right?
Yes.
Okay. What else?
HIV.
HIV, she said. Okay.
We used to see congenital syphilis, not now seen congenital syphilis. As he said, sir, I agree that this looks like an ongoing story right from prenatal period, and it is just going on. Birth is just one event that has happened in the history of this particular child's lifetime. That stereotype began, birth occurred, but he continues to be unwell, as if the sickness is progressive. I agree with you, sir.
Don't forget tuberculosis, not in this patient, but tuberculosis also continues in the mother, right?
Even a CMV, for example,
CMV,
you may get the virus in the urine also.
Yes.
Okay. Sometimes the toxoplasma damage may occur later, but not an active infection for a long time. So I think we keep possibilities of some, again, several antibiotics off and on. Maybe now all bacterial infection must have been treated, ruled out or whatever. That means we are looking at something unusual cause of fever. Is it unusual infection or totally unusual thing? I think was it totally due to temperature regulating system abnormality, then he would not have been free of fever in between. He would have had ongoing fever without disturbing the health, like a hypothalamic abnormality or like an autonomic nervous system. For example, a Riley-Day syndrome. Okay, a child cannot sweat and therefore he gets fever, environmental. All those things look unlikely because there is a rash coming, there is an edema coming. So we stay put with possible prenatal acquired infection which has continued postnatally.
Or infection mimicking pathology.
So Dr. Anjali is asking, there is a significant history of sibling history. So do you want to discuss that and try to add any points on that?
So one sibling had a congenital heart disease and died. So how does that correlate to this in any way, if at all? What are your thoughts? So could that have been a congenital infection which has now recurred? catch question. So now, which congenital infections damage the baby in the next pregnancy also?
Syphilis, okay. What else? Say which ones do not. No, that will be also easy sometimes.
So if that was a heart defect and if that was congenital rubella, can it damage this time? No. Toxo? No. CMV?
So I think the first thing we want to know whether the first child had isolated congenital heart disease or something more. If there was something more, then we start looking at something that can repeat again. But if he had only a congenital malformation, then the chances of one sibling having a congenital heart disease, the chances of a second sibling having a congenital heart disease is about little more than what is in the community. Okay, if community is about 0.8%, 1%, this could be 4%, but nothing beyond that. Okay.
And also probably no link to second sibling having congenital brain malformation.
No, not at all.
With one sibling having a heart malformation. So, okay. So give us your differential, so impression, and then we go to examination.
One point that if we are discussing prenatal infection which is continued in postnatal period, then this infection possibly has started somewhere in the second or third trimester of pregnancy. Had it had started right on the first trimester, then it would have caused a permanent damage, and over time possibly the infection would have died out. So to that extent, malformations must not have been resulting out of this story, but a continued infection must be a problem if we are right in considering a congenital infection.
May not be related here, but one such child which has rash, hepatosplenomegaly and fever goes on is litter sieve disease. Those histiocytosis X that we see, most of them come a little later, but one which comes in infancy, which presents as rash and progressive fever and goes on, is litter sieve. We don't know whether there is hepatosplenomegaly because we often think of infections and we don't think histiocytosis X as an infection, but it's infection mimicking disease.
But why are we not thinking about a condition which has fever going on for a long time, there is rash, and it is neonatal, and we had some problems with edema, thinking probably renal. Mother also may have something. Any thoughts? Lupus, neonatal lupus. Why didn't we discuss neonatal lupus early on? What is not fitting here? It's a very bad way of asking a question, but does neonatal lupus have fever? They don't have fever, right? They have rash, they can have renal problem and many other things, low platelets, etc. But they very rarely have, or almost never, at least to my knowledge, don't have fever.
Impression. 5-month-old female child complains of acute febrile illness with rash with history of physiological jaundice, persistent mild encephalopathy without feeding difficulty, with a global developmental delay, with a sibling death due to cyanotic congenital heart disease. To rule out, first infective etiology, torch, then metabolic, and then genetic causes. On examination, patient was sick looking, flushed appearance, heart rate was 150 per minute, RR 38 per minute, SpO2 99 on room air, peripheral pulses bounding, and CRT was delayed, it's around 5 seconds. HGT was 131 mg per dl, pallor present, no icterus, cyanosis, clubbing, edema present in the bilateral lower limb, anthropometry is normal. Head to toe examination, Head normal in size and shape. AF open. 0.5 into 0.5 centimeter at level. No facial dysmorphism. Erythematous macular rash present, blanching to touch. Trunk normal. Spine normal. Genitalia normal. No neurocutaneous markers. No digital or limb abnormality. System examination per abdomen on inspection. Mildly distended abdomen, umbilicus everted, flanks normal, no dilated veins, scars, sinuses, flushed appearance present, erythematous rash present, palpation, soft, no tenderness, liver 4 cm below costal margin, soft, left lobe not palpable, liver span 5 cm, spleen not palpable, percussion, tympanic note heard. On auscultation, bowel sounds heard. Central nervous system examination, child is irritable, preferred to sleep. On cranial nerve examination, roving eye movements present, no fixing and following, perception of light present, pupil bilaterally reacting to light, pupillary reflex present, no facial asymmetry, sucking and swallowing normal, no nystagmus. Tone is normal in all four limbs on passive movements. And on pull to sit, there is complete head lag. Head held sitting, back is rounded. On axillary suspension, no slippage. Ventral suspension, head held in plane with the rest of the body momentarily. On prone position, lies flat on couch, no lifting of the head. Power, moving all four limbs. Reflexus is 2+, no clonus, and plantar is flexor. Sensory system examination, response to touch, position, temperature cannot be tested. Withdrawal response to pain. Cortical sensation could not be tested. No signs of meningeal irritation. No nystagmus or titubation. Irregular intermittent spasm of all four limbs noted. Primitive reflexes, Moro reflex absent. Palmar grass absent. Plantar grass present. Asymmetric toning neck reflex absent. Placing reflex present and walking reflex present. CVS examination, S1, S2 heard, no murmur. On a respiratory system, air entry bilaterally equal, no added sounds.
So the examination findings have added what to our thinking on history? What new things did we get on examination?
Maybe negative also.
You all want to say anything? Always, most welcome. You can say anything. Tell us.
Child is well grown till now, but at present the child is sick.
I missed the weight. How much was the weight?
5.5 kg between -3 and -2. 2.5.
So, how come impression normal?
Yeah, that's what I'm.
Why did you say normal growth? When it is -3 to -2, 38 centimeters, 5.5, 64 centimeters length, 8-month-old child.
5 months. 5 months.
Even then 38 is low.
2.5 at birth.
3 kg in 5 months.
Okay, but what length and head circumference 38.
So we don't know the birth head circumference, but it is on the lower side.
And AF is only 0.5 into 0.5 centimeters.
Okay, AF is 0.5 to 0.5.
When is the AF maximally open?
No, not overlapping.
In a normal child, when is the AF maximally open? at birth it is there, then does it go on increasing and then decreasing? I'll give you a hint. The rate of increase of head in the first 3 months is very high. So is there an apparent increase in the anterior fontanelle? The answer is yes. Because closing of the fontanelle rate is not as much as increase in the head circumference. And therefore anterior fontanelle is the widest at about 4 to 5 months because the head has increased by as many as 6-7 centimeters. While the closing of the anterior fontanelle is not at that. So if you say a wide fontanelle at 4-5 months, it's okay. But if the fontanelle is too small at 4-5 months, then it is not very normal. You are not going to see a very small point unless the head is also small.
Okay, what else did you pick up on examination extra from after the history? Sorry? Hepatomegaly, but then he didn't tell us the span.
5 centimeters.
5 centimeters. So is it enlarged? And then he also said it's soft.
And out of 5 centimeters, 4 is outside. Isn't that so?
Yes.
That means, is it a pushed liver?
When checking liver span, I got 5 centimeters only.
No, so it almost means that it's a push down liver and it's not, if those readings are right. Okay, what else? What about the general condition of the child?
What is there a comment on the roving eye movements? It said the roving eye movements, searching eye movements. So defect is anterior or posterior? When do roving eye movements occur? What is the child trying to do when he is trying to do roving eye movements? He is trying to catch the image at the most sensitive part of the retina. So when problem occurs even before the development of that retinal, so to say, fixation, then they have roving eye movements, and in cortical blindness they will not have roving eye movements. So he has anterior segment problem rather than posterior, though we expected the problem to be posterior, but it is not. Or anterior and posterior both may be.
What else?
Reflexes.
Reflexes have not been achieved.
The neonatal reflexes, you mean. So what does that mean?
At 9 months there should be age appropriate reflex has not been achieved, like palmar grasp, developmental milestones have been affected.
So has he not developed a palmar grasp or has he lost a palmar grasp? When do you lose a palmar grasp?
3 months.
3 months. Why do you lose it at 3 months? Any reason? Why not at 6 months?
Initially the fist will be closed. Initially the fist will be closed all time. Then it opens.
Yeah. So basically many of these reflexes are connected to the achievement of the next milestone. So unless you lose a palmar grasp, you will not be able to go for objects and grab objects. So baby goes for objects at 3-4 months, and that's why the baby has to lose a palmar grasp before that, right? So here for this 5-month-old baby, absence of palmar grasp could mean either way. What else? So what's bothering you?
Not developed.
Not developed asymmetric tonic neck reflex. So that is delayed or not achieved, right? Then which other reflexes? So morose is absent. So what does that tell you? Again, I mean, for a 5 month, normally morose is present.
No.
Absent.
It's absent at 5 months. Yeah, yeah, yeah.
So neonatal reflexes are lost at right age.
Just as Dr. Rajesh said that one has to lose the palmar grasp, one has to lose ATNR in order to do what? Rolling over. No? So at around 4.5, 5, 6 months, up to 6 months it's okay, but even at 5 months if you don't have ATNR, you're all right with it.
Yeah, placing reflex and stepping, walking, stepping. What's your comment on that?
Placing reflex is normal at this age, because when we try to keep child on leg on the side edge of table, and that time child try to put, it is normally.
Okay. So is there something like a plantar grasp? What is that and what is the importance? He said plantar grasp is present. So what is the importance of that? Is that lost, not lost? Same logic, no? Like we talked. So what will follow after the plantar grasp is lost? Walking. So before a baby walks, the baby has to lose a plantar grasp. Otherwise, baby won't be able to walk. Right? Okay.
But same as you have to lose something to gain something. What do you have to learn before you learn something else? So before walking, what do they have to learn? Which reflex? Before walking, what should I learn? Sorry?
No, stand without support is a stage.
Stand without support is fine.
Tushar is asking which reflex you have to achieve.
If I want to do skydiving, what do I wear? A parachute. Right? So if I don't know, my parachute reflex is not good. Every time I try to stand or walk, I will fall flat on my face. It's difficult to pronounce. All F's are there.
And what is parachute reflex? It appears at 9 months and disappears at?
Never disappears. Very good. Okay. So I think except for the fact that this baby looks a little sick, as in tachycardia and bounding pulses and a rash all over, erythematous blotchy rash, from the point of view of the original disease or etiology, examination hasn't really added anything, right?
I think head circumference is definitely small. Okay, whatever it was at birth, 38 at 5 months is not. So there has been a prenatal cause. Whatever cause, that much we were sure. This child has come just now with an acute sickness. Okay, that's why tachycardia, CRT has a little more. But that is just an effect of something that has happened, maybe related or unrelated to the previous story. So all that we have learned is now that there is a prenatal cause for a delayed development, and this child seems to be susceptible to some progressive fever of which we are not able to pick up the correct etiology. So putting two together, if we want to put two together, then we still consider a maternal infection, but two may be totally unrelated. But why should a child who has a delayed development due to some prenatal cause run such a course of a long-term fever? That's also unusual. Again, this child is in the house only. There is no maternal contact or other family contact of infection. Infection is not of the type which is getting worse or getting better. And to that extent, this is not a partially treated infection. Had it been a partially treated pneumonia, you would have found some part of the problem still evident. Same thing about the UTI, we would have easily picked up. Same thing about meningitis, there could have been a hydrocephalus, large skull, as an evidence of a partially treated. So to me, this is not a partially treated bacterial infection. So this must be a persistent infection. And to tie up with an antenatal cause, we tried to kind of put together and say persistent of a maternally transmitted infection. We don't know beyond that what's happening. Okay, let's see whether investigations, what investigations would you do? You will do a CT, MRI, etc. But will that tell me the etiology? So what's your guesswork? Come on, none of us have seen what has been done. What investigation would throw some light on etiology?
Blood culture.
Give a thought.
Blood cultures.
You are all talking good.
Say it, doesn't matter.
Blood cultures will do.
Blood cultures, you said. Okay.
We said that if the story is of the same infection, then it's not bacterial. But you are right. He could have come with some bacterial infection and we need to pick that up. But that must not be enough to explain all that is happening all along.
VDRL, she said. Okay. Torch titer. Okay. Oh, at 5 months, if you do torch titer, it's extremely difficult to interpret that. But yeah, okay, torch titer. Ophthalmic examination. What are you looking for?
Cataract. Any cataract.
2D echo.
2D echo, she said. Okay.
Even the fundus and changes in the retina, chorioretinitis, etc. Tell us what.
Anything on the skull, an examination, any swelling, bony swelling or anything noticed? No.
I think the liver is abnormal, though the span is 5 centimeters. If 4 centimeters is below, I can't imagine only 1 centimeter is subcostally. So I would think of LFT, and I might even consider liver biopsy if we have to get. Some diagnoses are made only on liver biopsy. Like for example, one of the tuberculosis is diagnosed only on bone marrow examination culture. So I would think liver biopsy, one of the things, because I have nothing else to prove or go anywhere else. The only abnormality is here, and I will not spare that.
Any primary immunodeficiency that you are thinking of? We agreed that primary immunodeficiency, we want somebody to come and give it to you, but now you have taken the kid to the hospital, multiple places. So he's picking up a new bug and it's difficult to get rid of. Any thoughts on that? What are the points against it? Let's just think that way. It could still be PID. I mean, we're not debating that.
The weight gain and development.
Okay, weight gain and development. Then head circumference. Okay, that's another thing which is not in favor of it. But it could still be. So can it be any malignancy? Though we don't see them at this age. Any, as Sir said, whether we are thinking about histiocytosis or some leukemia or neuroblastoma. Though neuroblastoma doesn't come with fever for so long, but if you have a rash and a child who is having illness on and off, just thinking out of box.
Tell us.
Outside investigations, blood culture and urine culture showed no growth. Urine RM was normal. CRP was 14 and then 34 milligram per dl at 10th February. Serum creatinine normal. USG abdomen and pelvis was normal. USG cranium normal. Malaria was negative. Serum ferritin was 136. On LFT, total bilirubin 4.45. Direct bilirubin 1.97. SGOT 49. SGPT 18. ALP 337. Vidal was negative. TSH 5.47. On serum iron study, transferrin saturation 21.7, serum iron 63, TIBC 290, ferritin 136. Complete bleeding profile, PT was 11.3, INR 0.9, APTT 40.1, GGT 134, DCT ICT negative, sickling negative, LDH 308. On lumbar puncture, there was only 5 cells. lymphopredominant, protein and sugar normal, CSF culture showed no growth. On torch titer, CMV, rubella and HSV, IgG positive, MRI brain normal. Then it was CBC, HB was 6.4, WBC 6700, platelet count 5,62,000, hematocrit 21. On peripheral smear, mild anisocytosis, WBC normal, platelet adequate. Yeah, EEG done from our hospital, which was normal.
What do you make out of those liver function tests? Direct bilirubin. So how do you explain that? Dr. Kare was talking about liver being abnormal. Now you have abnormal liver function tests.
More than 20% of total bilirubin. Direct bilirubin is more than 20% of total. So it's direct hyperbilirubinemia. Liver, primary liver cholestasis.
But SGPT and GTT are normal. Okay. So what kind of this direct bilirubin is?
So is it hepatitis or is it a biliary tract disease?
Yeah, but SGPT is normal, GTT is normal. So where is this coming from? Do you think it's a Dubin-Johnson syndrome? Has nothing to do with illness at all. You have a direct bilirubin, you have a small degree of bilirubinemia, and nothing more. Okay. Or could it be, to my mind, a drug induced which is improving? After all, ceftriaxone, many antibiotics at this age, in a child who is certainly low in weight, malnourished, okay, edema, all that would certainly risk a drug toxicity. And therefore, we will really look at that. Okay. But doesn't look like a primary infection causing hepatitis. Oh, if it is going on from prenatal progressively, you would have a large liver and obviously symptoms of hepatitis or much more signs. So to me, it has been intermediate, some unrelated event, to me either drug induced or just to keep in mind whether it is an enzyme deficiency and nothing to do with what's happening. Biofire would find out the cause. Come back again.
No, serum protein was not mentioned. Anyway, it's okay. Sir is asking, will biofire help in this? Biofire. What fire? Means what sample? Come on, what are your thoughts? So you're not looking for any acute infection anyway, so okay, yeah. Go ahead.
Course in hospital. Patient was presented in septic shock. Noradrenaline infusion started. Started on antibiotic taxim and amikacin. Central line secured. EEG done normal. Fever spikes reduced. Dermat reference done in view of punctate erythematous rash over the body with a few vesicular lesion. Diagnosis of eczema herpeticum was made. Started on acyclovir. Patient symptomatically improved. Noradrenaline infusion stopped after 5 days. Patient developed persistent hypernatremia. IV fluids changed to 1/5 DNS. Hypernatremia corrected. Ophthalmology reference done. Showed small hypoplastic disc. Retina attached. No evidence of active retinitis. Advised senior reporting of MRI to rule out syndromic association. Visual acuity was not documented accurately as the patient was not cooperative. The patient is still having fever spikes. investigations. OLD was negative. Then optimum for dengue, leptospira and malaria. CBC, HB was 7.5, WBC 8,900, platelet 4,63,000, hematocrit 24, ESR was 22, CRP 48.9, total bilirubin 1.6, direct bilirubin 0.9, SGOT 240, SGPT 132, ALP 427, RFT 123 and creat 0.7, serum electrolytes 141 and 3.99, LDH 1493, CRP 38.4, serum calcium 8.3, serum phosphorus 4.7, serum lactate 42, blood CS showed no growth, MRI senior reporting done, we showed provisionally appropriate myelination with the corpus callosal agenesis. Serum B12 was 489, peripheral smear normocytic normochromic RBC, serum ammonia normal, TMS normal, urine osmolarity 120. Lymphoid, 69%.
I think only objection is a metabolic disease. Okay, why should metabolic disease be prenatal? So, to my mind, that is not right. Bilirubin seems to be coming down, so it's a recovering jaundice, and reasonably we can attribute it to drugs and leave it at that time. So the question is, we haven't been able to pick up an active disease, and to that extent we have no diagnosis really to that.
You've done a bone marrow?
No, sir, bone marrow was not done. So basically the child had exaggerated statal response.
Sorry?
So exaggerated statal response the child had. So like we thought of it was more of spasm type, infantile spasm type. So sir, we did one EEG for that to rule out Hib's arrhythmia. EEG was normal for the child. Sir, also we did ophthalmology senior reporting. So sir, they have found out bilateral optic disc hypoplasia in both the eyes. Sir, they initially thought of Aicardi syndrome. So sir, here basically there is infantile spasm, then optic corpus callosal agenesis and lacunae in the retina. But then this pathognomonic finding of retinal lacuna was missing. So again, so that's a female only. So this diagnosis was again out of the track.
But do they get fever like this? No.
So sir, fever, they were like, could be some secondary infection, that's why. PID workup we have not done, but we have sent RPR, rapid plasma reagent test in view of congenital syphilis.
See, to me, immunodeficiency should have presented with infection. And we are not looking at infection bacterial. Okay, same thing about the bone marrow. We are not anticipating anything in the bone marrow, but what Tushar wants to say is that one of the investigation for a PUO is a bone marrow. Okay. But in here, if you are asked what do you expect in bone marrow, probably nothing. But to prove that nothing is there, you need to do a bone marrow, because that's what we have done so many tests. I feel our discussion was reasonably right, coming to a conclusion that we don't have an etiology, and even at the end of all the tests, we don't have an etiology. So again, making a point that a clinical bedside medicine still has a lot of importance. Even to say that we don't know, and even investigation don't know. So it tallies our clinical impression. Okay. And I think to that extent, this was a good exercise. Even without knowing what is it correctly, we were thinking in the right direction, that we are looking at something which is active, but something that is not visible, something that has happened prenatally probably, and it is still active now. Okay. What bothers me is a good length and a small head and a little less weight. Okay. If this child is going downhill, then he should have gone down to length also. 64 length is fine for 5 months, but the weight is certainly with edema 5 kilos, 5.5. So weight is a little low, head is definitely low, but the length is fine. Do you want to see the parent's length and chart the mid-parental height to see whether this child has a tall stature genetically, constitutionally, or whether tall stature is an abnormality? What's your comment on that?
Edema had got decreased.
Because he presented on examination edema, that's why we thought.
Came with edema, then after 5 days it got subsided.
Okay, if that is so, then we come to a conclusion what we started discussing to begin with. Has this child failed to maintain health or has not failed to maintain health? If the weight is without edema, then 3 kilos more in 5 months is reasonable. Okay, which means that such a prolonged illness has not caused any health deterioration. My way of going further would be that itself would have said that we don't have a progressive illness. Then what is it? Is it something wrong with the temperature regulation system of which we are not able to pick up anything? I would even inquire whether this child has tears when he cries. Does he sweat when the fever comes down? It might give us an idea whether there is an autonomic nervous system dysfunction, and we are looking at infections or all inflammations. Of course, rashes, etc. And child in shock. So the point is that shock is something that has happened because of our interventions, infections. Okay, because shock has come at such a late age of progression, that shock has not come early. Okay, so all that is improving now. So I feel repeated hospitalization, repeated investigation have been a nidus for repeated infections. But the story continues in spite of all that. And in spite of that, the good weight and good height with a prenatal damage. My thinking now is whether there is really something wrong, and what you should possibly do is stop all the drugs and just give paracetamol SOS and see what is happening. That may be an answer to that. Anyway, it was a very good presentation, and thank you for doing that, and good discussion on all that. I think it's already 7:50 now, and we possibly we have some presentation, but we will not do that because that will take another 20-30 minutes, so we'll go past that. So if you all agree, then we'll skip that part. We have had enough brain scratching, and we are all convinced how little or how nothing we know. Well, we go out with that kind of a knowledge. That is not bad. Yes?
Anyone wants to say anything, any questions, any doubts? Okay.
You're all undergraduates. Very good. I think you should also start talking. Today's discussion must have given you a boost to say, even these Johnnies don't know anything at all. They keep on talking. Why don't you also start talking, isn't it? All right?
Okay. So we thank all our online friends who are watching the class, and also Dr. Palniraman, Dr. Baldev Prajapati, and Dr. Anjali, and all our other faculty. Thank you very much, and we meet once again next Thursday at 6 o'clock. Dr. Hemat Joshi wants to say something.
I want to tell you something about fever. I had a tiny baby like this who came with 103 fever, Adivasi child. Normally, if a tiny baby comes, infant comes, 1 month, 2 months, 3 months, you admit a baby with 103 fever, you do sepsis screen, then you put an antibiotic maintenance, and then you will wait for the reports. And when the reports are negative, and if you have guts, you stop the antibiotics, and then the baby goes home after 3-5 days. So we have a group, we are 5 people. So I asked my friend, they said, yes, simple, do a screen, admit, put IV lines, whatever. The lady said, I don't have money for food. I don't know how I have come to you. So I asked her, where did you get the fever first? So she said, when I was feeding, I felt the mouth warm first, and then she said, I felt it on the skin and not on the mouth. When I asked her, Then we take skin and mouth of every child in our place. So the baby's skin temperature was 103 and mouth temperature was 100. So obviously it was summer and the child was wrapped and it was a dehydration fever. So we bathed the child, we gave mother's milk, we gave ORS, and the baby went home and the baby was all right. Number one. Number two, pre-COVID time, we had 1200 admissions in 2 years. So we, as I told you, we take core and skin of everybody. So in 630 patients, the skin temperature exceeded the core temperature, means they all came with heat fever. And they all went home without antibiotics, with just fluids, oral and IV. So next time if you follow this practice, your rate of giving antibiotics might go down by 50%.
I think heat fever is one, you can diagnose it clinically. And how do you diagnose? Child has high fever, but even the feet and hands are as hot as the body. Whereas all other high fevers, the feet and hands are cold. So make a habit of putting your hand on the feet and on the tummy. If all are equally hot, it's heat fever, do nothing.
Yeah, and we have those infrared things. Yeah.
Okay.
But we can use anything.
Sir, we'll stop the online clinic or, yeah. So thank you everyone, and we switch off for today and we meet next Thursday at 6 p.m. Thank you. Switch off. Switch off.